Welcome, everybody. Today's discussion is coping with gynecologic cancer treatment-related side effects with Dr. Theresa Shao. In this discussion, Mount Sinai Hospital oncologist Dr. Theresa Shao will present about common treatment-related side effects from chemotherapy, PARP inhibitors, and immunotherapy used. In terms of Dr. Shao, her background is after graduating from Yale University and earning her medical degree at the University of Pennsylvania School of Medicine, Dr. Shao completed her internship and residency at Mount Sinai Medical Center, New York. She continued on to complete her fellowship in hematology oncology at Columbia University Medical Center. Dr. Shao is currently a medical oncologist at Mount Sinai Chelsea, specializing in breast cancer and gynecologic cancer. Her research interest focuses on treatment-related toxicity and survivorship. She is also interested in racial and ethnic disparities in cancer diagnosis and treatment. Dr. Shao, thank you so much for joining us. The floor is yours.
So thank you, everyone. I'm so glad to be able to join the group and discussing about coping with gynecological cancer treatment-related side effects. So this is the outline of my talk. So I'm going to focus on these four areas. First is chemotherapy related side effects. Then we will talk about immunotherapy. After that, we'll be talking about PARP inhibitors. And lastly, I want to focus a little bit about antibody drug conjugates, which are the newer drugs for treatment for gynecological cancer.
Dr. Shao, if there are questions for you, should they write them in the chat and then save them for the end?
Yeah, maybe. Would that be better? Because it will be hard for me to see the questions. Absolutely. I mean, unless it's really urgent, then, just sort of stop me and then I can. So the first one I'm talking about is chemotherapy, which is really one of the oldest form of treatment for GYN cancer. And as a lot of you guys are probably familiar with, these are the common drugs that we use for gynecological cancers, ovarian, uterine, as well as cervical cancer. So carboplatin, I think a lot of people are very familiar with it. Sometimes when we have allergic reaction to paclitaxel, we switch to what they call nab-paclitaxel, which is Abraxane, which is very similar. Otherwise, docetaxel is something that we also utilize. The second common drug is Doxil, which is liposomal doxorubicin. The third is gemcitabine, and the last one is topotecan. And obviously, there are other chemotherapy drugs, but those are the four I would think is most common chemotherapy we use. So in terms of nausea, I think this is one of the more common side effects that we see with chemotherapy. So the carboplatin, especially given with Taxol, historically, it was considered moderately immunogenic. But in 2017, NCCN guideline actually considered this more as highly immunogenic. So when you have an AUC more than 4, and they recommend using what they call a 3-drug regimen to help prevent nausea. So the other chemotherapy drugs I've listed, Doxil, gemcitabine, taxane, topotecan, they were all a single agent. They were all considered low immunogenic potential, and you only needed to have one drug, either an 5-HT antagonist or steroids as pre-medication for nausea. So what is the 3-drug regimen? So if you are giving chemotherapy with carbo and Taxol, those are the 3 drugs that we will give as medication to help prevent nausea. So one is corticosteroids, and most commonly is dexamethasone. The second one is serotonin receptor antagonist, which is what we call 5-HT3 antagonist. Most common ones are ondansetron, but what we use most often is what they call polynositron, because it's an IV treatment that can last for 3 days. So that's what we would prefer. And then the third drug in the regimen is a neurokinin receptor antagonist. Aprepitant is one of the oldest one. Now we usually use what they call fosaprepitant. Another name for it is called IV Amend. And that's also because it lasts for 3 days, and that's what we would prefer. So these are the 3 drugs we generally will give for patients when they're receiving their carbo and Taxol chemotherapy. And obviously, patients continue to actually experience nausea despite the the 3-drug regimen. These are the 2 drugs that we will add as more sort of to help prevent delay nausea. So steroid, dexamethasone 4 milligram twice a day for day 2 and 4 after chemo, and then olanzapine, which is either 5 or 10 milligram giving at nighttime for 3 to 4 days, is also very good to help prevent some of the delay nausea. And then with the 3-drug regimen as well as this, we have really actually controlled the nausea for chemotherapy quite well. Very rarely we have patients who will have significant nausea after these drugs. And obviously, these are the, even despite these regimens, if patients still have, nausea, we also give rescue medications. So ondansetron, which is one of the common one, which is the 5-HT3 receptor antagonist, Zofran being the most common one in the class. We can also use D2 receptor antagonist, which is prochlorperazine. Compazine is the trade name for it. And then the third one is dopamine receptor antagonist, metoclopramide, which is Regimen. And then last one is we can also use benzodiazepine, which is also provides some effect and anxiety. So lorazepam, Ativan is what we commonly use. So these are the rescue medications that we can use if patients still develop nausea, vomiting after what we have given the 3 regimen, as well as the rescue, the steroid and olanzapine. And then next one I want to talk about is more what we call chemotherapy-induced peripheral neuropathy. And that's what we usually see is with the drug taxane. So Taxol, paclitaxel, nab-paclitaxel, docetaxel. It's a very common, which it can be long-lasting toxicity for many cancer patients, and up to 68% incidence with taxane. And it can impact the quality of life and ability to administer more chemotherapy. And this is dose dependent. And then what we do know is docetaxel causes less neuropathy compared to paclitaxel. Unfortunately, there's still no effective pharmacologic agents for prevention. And then there is some promising preliminary data with compression therapy and cryotherapy, but these are small, non-randomized and self-control studies. And there is also some tolerability concern with cryotherapy, which makes them less attractive, or we don't really use standard. So here is the ASCO recommendation for treatment. So if you do develop sort of chemotherapy-related peripheral neuropathy, duloxetine is what we highlight here. It's really the only medication that's been shown to be somewhat beneficial with a very low risk for harm. Other than that, we also use gabapentin, acupuncture, exercise, but none of these drugs or sort of treatment has really been shown to be beneficial in a randomized control studies, although their potential for harm is very small. So we do have patients who do utilize these drugs as well, but that's for treatment. In terms of prevention for chemotherapy-related neuropathy, there are many drugs that have been studied, and as you can see in this chart, basically ASCO do not recommend any of these drugs or any of these drugs for prevention, because none of them have been shown to be helpful, and some of them have actually shown to be harmful. So carnitine as well as DDTC, they definitely do not recommend. And then all the other drugs, even though some of them have very low potential for harm, but there's also very low, sort of benefit. So we don't recommend really any of these drugs. And then, so in terms of non-pharmacologic agents, we know a lot of patients have wanted to use acupuncture, exercise, and sometimes compressive therapy, as well as cryotherapy. So, as we all know, that haven't been any randomized control studies. All the studies have been very small. And then the benefit is also of low quality. And there is some potential for harm, especially with cryotherapy. Sometimes if you don't use it appropriately, the fingers, or the toes can, get harmed. And currently, there's no really effective prevention, but there is an ongoing clinical trial led by the SWA group called the ICE Compress trial, where they're looking at patients, all solid tumor patients, being treated with either paclitaxel or carbotaxel or carbodocetaxel. And these patients are randomized 1:1:1 to 3 different arms. One is an arm with cryocompression. So you get the cold therapy as well as, compression. The other is just continuous compression with 25 millimeter Hg continuously. And the third arm is with a low cyclic compression, so cycling every 5 minutes. And the primary points will be if there's any clinical meaningful reduction in chemo-induced peripheral neuropathy. So this is an ongoing trial. Hopefully in the very near future, we may have more data in terms of what will be the best treatment or the best preventative strategy for neuropathy. But right now, there's really nothing standard that we can recommend or utilize. And then lastly, I want to focus is about chemotherapy-induced hair loss. So what we do know is FDA have approved 2 scalp cooling systems to intend to prevent hair loss during cancer treatment. One is the Dignicap, the other is Paxman. And here, at our cancer center, we do have the Dignicap machine that we can utilize. So what does scalp cooling mean? So basically what it does is it introduces cold temperature by inducing vasoconstriction. So you reduce the metabolic activity and then reduce chemotherapy to the hair follicle. As such, instead of losing all your hair, patients may end up only losing about 20 or 30% of their hair. In order to be effective, you have to start applying the device 30 minutes before chemo. And many times you have to keep the cooling for another 2 or 3 hours after finishing chemotherapy. Obviously, in order for it to be effective, you have to have the correct size of the cap, texture, and then also, the thicker your hair is, sometimes the better outcome that we see. And these are the Dignicap and Paxman are 2 FDA-approved machines. The Penguin Cap has been utilized. It's the oldest one. It's actually not FDA-approved, but patients do utilize it. It's basically caps in the dry eyes, and you have to replace the cap every half an hour. But the idea is very similar. And then, so the study that got FDA approval for Dignicap is based on patients with stage 1 to 2 breast cancer receiving adjuvant or neoadjuvant chemotherapy. And there were 100 patients in the standard, in the treatment group and 16 patients in the control group. And most of the patients got chemotherapy with cyclophosphamide and docetaxel. And what they find is, there was improvement in hair loss in 66.3% of patients. And then many patients also find it, to be, helpful. And that's the reason why Dignicap is approved for use. And it was mainly for breast cancer patients. But obviously, we also utilize it for a lot of our GYN patients, especially patients who are undergoing carbo and taxol. And so far, safety-wise, is generally has been shown to be quite safe. And for most of the solid tumors, there's very rare chance of scalp metastasis, so it seems to be safe to be used. It's also overall well tolerated. Sometimes patients can have a little bit headache or feeling very cold, and sometimes a little bit nausea and dizziness. But in general, most of the patients will be able to tolerate the use of the cooling cap. So this is the 3 areas I focus on more for chemotherapy. Next, I want to talk to you is more about immunotherapy. And this is we have been utilizing more and more in our treatment for the GYN cancers. So what we do know is pembrolizumab, another name is Keytruda, and dostarlimab, another name for is oh my God, blanking out, Gynpari. So they are both PD-1 inhibitor, and they're approved for uterine cancer. So they were approved for stage 4 uterine cancer, but now there's also that patient with stage 3, especially if you have measurable disease, can also be utilized in combination with chemotherapy. And then obviously Keytruda is also approved for cervical cancer now in the stage 3 and 4 setting, as well as for recurrent cervical cancer. And then what we do know is immunotherapy has a very different side effects, than the traditional chemotherapy. And what we mainly see is what we call immune-related side effects. So with rash and itching being the most common, we can sometimes also see diarrhea, colitis, and then we can also see what they call hypophysis, which is the endocrine-related side effects. A lot of times, thyroid dysfunction is the commonly associated one. And then lastly, we can also see liver toxicity. So those are the four more common side effects that we see. Rash and itching probably is the one that happens the quickest. The onset is usually about 3 or 4 weeks, and then it peaks around 6 weeks, and then it generally will sort of resolve. The diarrhea is a little bit later, so usually started to happen around week 5 and peak around week 9 or so, and then sort of it will usually resolve. The thyroid dysfunction, and these are usually happen a little bit later, 6 or 7 weeks later. But as you continue on treatment, these side effects actually sort of persist. And then the liver toxicity can also happen a little bit later and can persist for a while, and then generally around 14 weeks or so, then will sort of start to subside. So the first, what we usually see more commonly is what we call skin toxicity. So erythema, the most common that started usually earlier. A lot of patients will start with just itching, a little bit bumps here and there. If it's less than 10% of your body surface area, it's considered grade 1. And usually topical steroids and some good sort of hydration cream or anti-itching cream is sufficient. And usually we can continue with treatment. However, if you started to go on to grade 2, which are rashes much more often, sometimes covering about 10 or 30% of their body surface area, even though, so this is sometimes we have to think about, the risk and benefit of treatment. We do continue with steroid and cream, and many times we continue with immunotherapy, but a lot of times we will refer patients to see dermatologists and then see if there are any other things that we would do. Once you get to more than 30% of your body covered with rash, then we will have to hold the immunotherapy. Many of these patients will have to initiate with steroid, or oral steroids, and sometimes IV steroids. And then after, if the skin toxicity sort of improve or decrease, then we will actually reduce, taper slowly the steroids. Once you taper the steroid to less than 10 milligrams, we can many times resume immunotherapy, again. But this we will have to work very closely with the dermatologist. And then the next one we talk about is very commonly is seeing thyroid sort of dysfunction. So we commonly monitor TSH and also free T4 during our immunotherapy treatment. If they're abnormal, many times we would like to refer patients to see endocrinologists and work with them to see, whether patients will need to be repleted with thyroid hormones, or sometimes patients can have hyperthyroidism needing additional medication. Many times when patients are asymptomatic, we don't need to hold treatment, we can continue. But obviously for patients who are having thyroid storm or many side effects from the immunotherapy, then we will have to hold immunotherapy and then resume until these symptoms resolve. And similarly with liver toxicity, if it's mild, some just very, very small elevation ALT/AST, we would generally continue treatment. Once we get to more significant rise in your liver enzymes, we will have to hold the treatment and then sometimes initiate oral prednisone until the liver enzymes goes down. And some patients we can re-challenge, some patients who, if the LFTs went up significantly and we worry about re-challenge, we may permanently discontinue immunotherapy. But in terms of re-challenge, we will usually work with the liver doctor and then figure out what would be the best option to do that. And then lastly, in terms of the GI side effects, so diarrhea is the most common. As you know, chemotherapy can cause diarrhea as well. Sometimes it may be hard to differentiate between the two. If it's mild, such as grade 1, usually we just do supportive care with immunotherapy. Once you get to, more than 5, diarrhea per day, then, we sometimes worry that it could be immune related. And we usually would like patients to be examined closely. You need to rule out infectious cause, and sometimes patient may need a colonoscopy. If there's any concern that's immune related, we will promptly start steroids, and many patients may need to be admitted to the hospital for hydration and everything. The good thing is, these GI toxicities are pretty rare, but we do have to have a high vigilance for it, just because I said with a lot of chemotherapy, it causes diarrhea. So sometimes it may be difficult to differentiate between the two. But otherwise, immunotherapy is usually very well tolerated. And if for many patients, they do not have any side effects, and they can continue immunotherapy for long periods of time. And this is the same. So that's the second about immunotherapy. The third one I want to talk about is the PARP inhibitors. And this is most commonly used, for ovarian cancer. And we have 3 PARP inhibitors that's approved for use. One is niraparib, the other is olaparib, and the third one is rucaparib. And even though they're all PARP inhibitors, they're not all the same. So what the common and adverse sort of events that we see in clinical trials for all the PARP inhibitors are nausea, vomiting, sometimes a little bit fatigue. We do see anemia in all of the PARP inhibitors. Thrombocytopenia, we do see that, and that's more commonly associated with niraparib. We also see neutropenia, dyspepsia, and anorexia. And then, as we all know, that these side effects can be influenced by whether patients receiving the first line treatment versus later lines. And also it can be affected by your weight and platelet count. The older you are, sometimes patients may experience more side effects. And obviously we also need to be mindful of what are the common medications that patients use. So some of the prescribing strategies to help prevent adverse events from the PARP inhibitor. So what we always want to make sure is patients are really fully kind of recover from chemotherapy. So the highest symptom burden usually reported in the first 6 weeks post-chemotherapy. So usually we want to wait until probably maybe 6 weeks after chemotherapy to start the PARP inhibitor. And then obviously, if you already have baseline nausea, or if you already are weaker, more fatigue after chemotherapy, patients may experience more, sort of side effects. And sometimes you may want to consider starting at a lower dose of the medication for better tolerability. And then, as we said, there's no urgency to start patients who already have a complete response following chemotherapy, and certainly don't start less than 28 days after the last cycle of chemotherapy, because we want to make sure the bone marrows are fully recovered. And then in the first line maintenance trials, many of these patients actually begin these PARP inhibitors within 8 to 12 weeks of finishing the last chemotherapy. So there's no rush to start right away. We can start, within the second or third month after finishing chemotherapy. And sometimes starting a little bit later can help prevent some of these side effects from the PARP inhibitor. And then in the clinical trials that prescribe the PARP inhibitor, they also, all the patients, had a hemoglobin more than 10 with no blood transfusion in the past 28 days. And the white blood cell count has fully recovered. Platelet are also more than 100,000. And then liver enzymes and kidney functions are normal. So that's usually what we would like patients to do as well before we start the PARP inhibitor. And then obviously we do know is olaparib is a substrate for the CYP3A4. And so if you co-administer a strong CYP3A4 inhibitors with olaparib, it may increase the plasma concentration. And sometimes if you do an inducer, it can decrease plasma concentration of olaparib. So you want to make sure if the patients are on any of these medications, we do want to reduce the starting dose of olaparib. And then, as you can see in clinical trials, there is a very high dose interruption, dose reduction, and also as well as discontinuation in all the PARP inhibitors. So it's very common that we have to hold the medication or dose reduce the medication for the PARP inhibitor. And then, so what to do? So nausea and vomiting is the most common side effect we see with the PARP inhibitor. So we always say, maybe consider a light meal prior to taking a PARP inhibitor. And for niraparib, which is the Jula, because it's a once a day dosing, maybe taking at nighttime prior to sleep will be helpful. And if you experience nausea and you may want to take nausea medication as needed, or sort of sometimes, to take it 30 to 60 minutes before a PARP inhibitor could be helpful. And if the nausea vomiting is really persistent, we may want to interrupt treatment for a few days. And once it's resolved, we may want to either start at the same dose, but with prophylactic antiemetics, or sometimes you can reduce the dose. And of course, if symptom persists and a very high grade, you want to start at the lower dose when it's resolved. And these are the medications that we can use as needed for nausea. So, and then most time, the nausea is usually still low grade and self-limiting, and vomiting is very uncommon. And then the other side effect that we hear very commonly with PARP inhibitor is fatigue. So, one thing is so good is to tell patient fatigue is very common. So if you do experience fatigue, it is something that, everyone will see. It does generally improves over time, although sometimes it can, persist. Obviously we want to make sure patients are not anemic, does not have hypothyroidism, is not depressed. And sometimes, we want to make sure the menopausal symptoms patients are experiencing are not really causing more fatigue. These are some of the non-pharmacologic things that we can do, afternoon nap, massage therapy, sometimes psychosocial intervention. Obviously exercise is always very good. Ginseng or Ritalin, very rarely we prescribe Ritalin, but ginseng is something patient can consider. And sometimes, if the fatigue is really significant, we can dose interrupt or restart at reduced dose. But in the clinical trials, only less than 2% of patients actually stop the PARP inhibitor really due to fatigue. So even though it's common, usually it's still pretty mild or grade 1 for most of the patient. And then hematological toxicity is more common, and it's really seeing all the PARP inhibitors. And that's the reason why we will have to monitor the CBC very closely. Usually we want to make sure hemoglobin is above 10 and the white count and platelet count is near normal before we start treatment. And for olaparib, we usually want to monitor CBCs monthly for the first 12 months. And after that, usually every 2 to 3 months. For niraparib, usually we want to do weekly CBC for the first month, and then monthly once the CBC is stable. And then, so in terms of anemia, so grade 1 anemia is 10 to 12, that we don't have to do anything, we can just continue and monitor. Once you get to less than 10 grams of hemoglobin, we usually want to stop the medication and then restart until when the patients get to 10 to 12, and many times we may have to consider dose reduction. And if it's less than 6.5 or less than 7, we usually want to interrupt, and many times we do have to transfuse patients. And for certain, we want to restart at the lower dose. And then if the patient's CBC do not recover to grade 1 after 4 weeks, you may want to refer a patient to see a hematologist to have a further evaluation. And then the other thing we look at commonly is thrombocytopenia, and that's most commonly seen with niraparib. So usually we don't start the niraparib until platelet count is more than 100,000. And then if they ever have a platelet count less than 75,000, we do have to sort of hold the medications and until they recover, and then usually resume at a lower dose. And obviously, if the platelet count do not recover within 4 weeks, you do have to refer them to see a blood doctor just to be, just to have a more other workup to evaluate for other types of thrombocytopenia. And this is sort of niraparib is what we commonly see. And that's the reason why for the first 4 weeks after starting niraparib, we want to check the CBC very closely. And neutropenia is usually not as common, especially if it's low grade. We usually just continue to monitor. If it's less than, if it's grade 2 or above, then we may have to interrupt and monitor and then resume at a lower dose until they recover to grade 1. But neutropenia is usually less than 2%. When we have to stop or hold the treatment. And then the other thing that we can see a lot is dyspepsia, which is just feeling of, sort of irritation in the sort of stomach area, or alteration in taste, which can occur up to 40% of the inpatient taking a PARP inhibitor. So it's always good to tell patients that you may experience, dyspepsia or alteration in taste. And most of the time, we just offer supportive care and practical advice. So increase fluid intake, modify meals so that you can improve the flavor. Sometimes, maybe changing food temperature can be helpful. And then you can also avoid food that can exacerbate your symptoms. So, patients may want to keep a food diary. So those are the things that you can help to manage some of these symptoms. And these are the other laboratory abnormalities that we can see, increasing creatinine, increase your liver enzymes, hypomagnesemia, and sometimes increasing MCV. Most of these things are very, it's usually rare. And then a lot of times, we don't really have to do much. We just have to educate the patient. With the magnesium, sometimes we may have to supplement with magnesium medications. Hypercholesterolemia can be seen with rucaparib, and that's something that we do have to monitor, and sometimes patient may need to take a cholesterol medication for this. Lymphopenia is extremely rare, and then we also have to sort of rule out chronic infection. So this is something that a lot of our patients are worried about. So what is the MDS-AML that is associated with PARP inhibitor? And then what we do know is incidence of these sort of leukemia or myelodysplastic syndrome has increased with the introduction of PARP inhibitors. It's very low risk if you are using as the first line trials as maintenance treatment. So after chemotherapy, the first time you use these PARP inhibitors, the risk of developing MDS or AML is very rare. Higher risk can be seen in recurrent setting or after multiple lines of chemotherapy. So can be up to 8%. Risk factors include, older age, if you have used multiple lines of platinum-based chemotherapy, if you have BRCA mutation, or if you already have what they call TP53 clonal hematopoiesis. So these are, factors that sometimes can increase your risk of developing MDS, AML. And that is the reason why if, blood count do not recover 4 weeks after stopping the PARP inhibitor, we usually would like to refer to see a hematologist to rule out potentially MDS or AML. But even, with this, it's still a very rare side effects. And most of the patients that are on PARP inhibitors would never develop this. And then and then just a little bit more about the MDS-AML. The median time to onset variable is usually from 7 months to 24 months. The risk factors we sort of discuss, and then we talk about if we have persistent cytopenia, especially more than 4 weeks, or if patients are doing well and all of a sudden they develop anemia or cytopenia. These are all sort of warning signs that we have to be evaluated with hematologists. And that's the reason why we do want to monitor your blood counts monthly in the first year, then at least every 2 to 3 months after. And then these are some of the additional side effects that we can see. So with niraparib, patients can sometimes experience hypertension and may need to be monitored closely. And sometimes, hypertensive medication needs to be added. PRES, which is posterior reversible encephalopathy, which is extremely rare and can sometimes be seen with niraparib if patient has headache or seizure. And that is something that, we need to be concerned. And it's usually treated by stopping the niraparib as supportive care. Pneumonitis is also a rare side effect, can be seen with olaparib or niraparib, and that's something that you have to investigate. A patient starts to have persistent cough and CT scan with findings of pneumonitis. And stopping the PARP inhibitor, initiating steroids is usually the treatment for it. And then with rucaparib, sometimes patient may also experience photosensitivity. And that just, we just counsel patients and they have to use sunscreen and hats. So that's the majority of side effect we see with the PARP inhibitor. And then lastly, what I want to cover is the antibody drug conjugates, which are the newer treatments that we have for the GYN cancer. So the first drug that's really approved, the antibody drug conjugate, is tisotumab vedotin, which is a tissue factor, which is a fully human monoclonal antibody that's conjugated to a microtubule inhibitor. And then the second that is usually that's used for is Tivdak, and that's usually used for cervical cancer in the second line setting. And then the second antibody drug conjugate that's approved is in ovarian cancer, which is Mirvetuximab Soravtansine. It's a human receptor alpha antibody, and is conjugated also to a microtubule inhibitor. And then what we do know is, so the first one I want to talk about is the mirvetuximab, and we know it's FDA approved in November of 2022 for the treatment of platinum-resistant ovarian cancer in patients with high folate receptor alpha expression. And in general, it's very well tolerated. The most common side effects have to do with blurred vision, keratopathy, and sometimes nausea. And then in the Soraya study, what we see is 52% of patients had reported any grade of blurred vision. Median onset is about at 1.4 months, so cycle 2. And it's usually very manageable with dose modification if needed. And it's reversible. 96% of patients with grade 2 or greater ocular events resolve to grade 1 or 0. And only one patient discontinued treatment due to ocular treatment-related events. And then, as we know nowadays, it is required to have eye care prior to start mirvetuximab, and then also while getting mirvetuximab after up to cycle 8. And then with these required eye care, we do find most of these eye-related side effects are very mild, usually grade 1, and many times we never need to stop treatment or lower the dose of the medication. And these are the eye drops that patients are usually recommended to have. You have to have the steroid eye drop for 9 days, 6 times per day, day 1 to 4, 4 times per day, day 5 to 8. Also, you want to use lubrication eye drops. So if you do all these prophylaxis with these eye drops, as I said, these side effects, the eye-related side effects, are usually extremely rare. And after cycle 8, just continue with these eye drops, but the eye exam are usually not required. And then the earlier drug, the first drug that's approved is Tivdak, tisotumab vedotin, which is approved in September 2021 for patients with metastatic or recurrent cervical cancer progressed on or after chemotherapy. And then, similar to mirvetuximab, the most common side effects are dry eyes. 29% of patients have it, and corneal adverse reaction, and sometimes blepharitis. And similar to mirvetuximab, there is also required eye care with Tivdak. So you have to have an eye exam at baseline, and then every cycle, and then additional eye exam if you have symptoms. And then also, they do require you to get steroid eye drops 4 times per day, day 1 to 3. And also for Tivdak, they also use a vasoconstrictor eye drops before and after infusion. And during treatment, you can also use lubrication eye drops. And during infusion, we also give cool compresses. And then with these prophylaxis used with eye drops and cool compress, I think the eye-related side effects are usually very mild or grade 1. And this is the website that you can get more sort of eye care-related treatment. So overall, the eyes are the main sort of new side effect that we see with these antibody drug conjugate. Otherwise, very little nausea, vomiting, and then hematological side effects are usually, mild and rare, and otherwise very well tolerated. So this is just a summary of, the antibody drug conjugate. So these are, most commonly caused what they call ocular toxicity, usually just on the surface of the eyes. Mirvetuximab, you can get corneal irritation. Tisotumab, you can get conjunctival or corneal. Vast majority of cases are mild to moderate, and they're highly reversible. Very rarely, you may require dose reduction, dose delay, but very rare discontinuation. And then once we add the prophylactic ocular regimen, so steroid, eye drop, vasoconstrictor, or cold compress, and then we monitor, eye exams regularly, these side effects are usually very mild, and many times we don't even see these eye-related side effects. And that's all I have. Thank you. Any questions?
Thank you so much, Dr. Shao.